We are live.
Okay. Good evening, postgraduates, and welcome to this 70th episode of All India Postgraduate Teaching Program, an initiative from ARC Airways. In this 70th episode, we will be talking about lamellar keratoplasty. Keratoplasty has been in vogue for probably 3 or 4 or 5 decades, but this lamellar keratoplasty has come in a big way in last a few years, and it has really taken the ophthalmic world by a storm. Also, this has been a question on lamellar keratoplasty as a long question in one of the MS finals. So, today's didactic lecture would be presented by Dr. Praful Kumar Maharana, who is an additional professor of ophthalmology at prestigious RP Center, All India Institute of Medical Sciences, New Delhi. My special thanks goes also to Dr. Arundhati Botakur, who is a consultant cornea and anti-segment surgeon at Eye Care Center, Guwahati. Dr. Sandeep Arora, who is a director of Sparsh Netralaya, again a cornea surgeon from Ahmedabad, and Dr. Ankit Harwani, who is a cornea, cataract, and refractive surgeon at Netrajot Eye Hospital, Amravati. So, without much ado, can I request Dr. Praful Kumar Maharana to share his screen and let's begin the proceedings.
Uh, I think you'll have to unmute me. I don't see that button.
We can hear you.
Okay, you can hear me. Okay. So
Yes.
thank you, sir, for inviting me for this talk. You know, postgraduate students are always very close to my heart, and it's a pleasure to take a lecture for postgraduate students, right? So before starting the lecture, first I would like to tell you all what is the role of lamellar keratoplasty in postgraduate exam, right? So most likely you people are going to get a essay type of question, as sir said, or in long cases, you may get a case like keratoconus or macular dystrophy or corneal dystrophy, where they may ask you about lamellar keratoplasty. Or say you get a case of Fuchs endothelial dystrophy as a long case, then in that case also the examiner may go into details of what you know about lamellar keratoplasty. Okay. But you don't need, or you are not required to know each and everything about lamellar keratoplasty. It's a topic for fellows, cornea fellows, and SRs. So in this lecture, what I will do, I would go through the main component, main parts of lamellar surgeries that you should know, and the few basic steps about that, and the overall classification, and the advantage and disadvantage of each of the technique. So that is good enough to get a good score in your theory exam. So being a corneal surgeon, you know why we are discussing this topic, because corneal surgeons are little bit blessed by the God. Why? Because you can see here, when the diseases affect cornea, to begin with, most of the dystrophy, they are quite restricted to one particular part of the cornea. We know cornea have 5 layers plus that Duas layer, added layer. So each layer is different, and you can separate that from the other layers. That is the best part of being a corneal surgeon. So that's why we are able to do lamellar surgeries. If the disease is in anterior half, go for anterior keratoplasty. If it is posterior half, go for a posterior keratoplasty. Or if the disease is restricted to one particular layer, then you can replace that also. Okay, so that is the advantage. So this is the review article that we published in 2018 in IGO, where we discuss this. This is now we call label these procedures as a component corneal surgery. In component corneal surgery, what we do, we take out the disease part. Say, for example, your enterostoma is diseased, then we remove that part only and replace it with a enterostoma from the donor. So that's why component corneal surgery, and each component of the donor cornea can be used. So as you can see here, overall cornea transplant can be divided into full thickness graft and lamellar graft. Lamellar can be divided into anterior and posterior. In anterior category, you have SALC, ALTK, DALK, and TILK. In posterior, you have DSEC, DMEC, and PDEC, and a bunch of hybrid techniques. So this is what the broad classification is. You can give this classification in your exam, or this is a anatomical classification of lamellar keratoplasty that we have discussed in the review article. As you can see, if you are transplanting the Bowman's layer, that is known as Bowman layer keratoplasty. If you are just replacing the stroma, it can be either entry stroma or it can be little deeper, deep stroma. In entry stroma, you have two techniques, SALK or superficial interlamellar keratoplasty, ALTK or intralamellar therapeutic keratoplasty, and to it you can add FALK also, femto-assisted lamellar keratoplasty. For deeper stroma, when the disease is involving deeper layer, you have two techniques, pre-decimatic DALK, decimatic DALK, or you can, few people divide it as a maximum depth DALK, big bubble DALK. But for ease of classification, you can remember like this, pre-decimatic and decimatic. As the name suggests, decimatic means you are reaching till the decimate layer and then replacing the diseased cornea. Pre-decimatic means you are not reaching till the decimate membrane. Rather, some stroma, as you can see in this chart we have discussed, almost 90% of the stroma is removed and little stroma and the decimate is still there. So that is the broader classification of this component corneal or lamellar keratoplasty. For posterior keratoplasty, you can label it as endothelium decimate complex surgeries. It can be decimate stripping automated endothelial keratoplasty or decimate stripping endothelial keratoplasty or decimate membrane endothelial keratoplasty or as I said, pre-decimatic endothelial keratoplasty. So either way you classify, either anterior posterior or anatomical classification. If you classify like this, you will fetch good marks. The next question is the examiner might ask you why lamellar keratoplasty, even if it is affecting anterior one third only, go ahead with a penetrating keratoplasty, go ahead with a full thickness graft. So there you have to know the advantages of lamellar keratoplasty over a full thickness graft. As you can see, the red parts are the lacunae of this procedure, green parts are the advantages of the procedure, and blue part are some logistical advantages that it provides to you. So when you are dealing with lamellar keratoplasty compared to penetrating keratoplasty, indications are limited. Yes, because in full thickness graft, no matter where the opacity is, you can go ahead with a full thickness graft. But in DLK, you have certain specific indications only. The second problem is since you are replacing one part, there is another host part is still there. There may be some hedge between these two junctions. That's a limitation of your lamellar keratoplasty. Suboptimal visual acuity. Even though it doesn't hold true, but if you go into the nitty-gritty of visual acuity, what you'll find in a full thickness graft, the quality of vision is better, but in lamellar keratoplasty, the quality may be not as good as your full thickness graft, right? But the biggest advantage, lamellar keratoplasty is an extraocular procedure. You know, in penetrating keratoplasty, you are opening the chamber, and that opens the Pandora box of all complications. To begin with, suprachoroidal hemorrhage. You know, once that happens, then the vision is almost gone. You cannot retrieve those eyes. That is a major threat with open sky procedure. And there are issues like wound related problems. It's a full thickness graft, and it has been proven no matter how good you do the suture, how tight suturing you do, the strength of the naive cornea is much better than a transplanted cornea. That means even with trivial trauma, there may be your graft host junction made, there may be dehiscence of graft host junction. Endothelial rejection. Since in lamellar keratoplasty, especially lamellar keratoplasty, you are not transplanting endothelium. In posterior lamellar keratoplasty, you are not giving that much antigenic load in contrast to transplanting full cornea. So the risk of rejection is definitely less. Astigmatism in lamellar keratoplasty, you know there are three interfaces. You are getting a 360-degree interface, and then there is two edges. So the surface area where the scarring occurs is much better, much larger in lamellar keratoplasty than a full thickness graft where there is only a circumferential scar. So that leads to better healing and in cases less astigmatism, especially in cases of endothelial keratoplasty. And lastly, good quality tissue. You know, in India, we are really short of donor corneal tissue. If you are planning a posterior lamellar penetrating keratoplasty, you need a good quality tissue. You know, optical grade tissue with endothelial count at least more than 2000. When you are doing a lamellar keratoplasty, especially the anterior lamellar keratoplasty, the endothelial count is not a limitation at all. Even in non-optical grade tissue, you can use. So that is a big advantage of doing a lamellar keratoplasty. So these are the other advantages of that we have enumerated in that review article. You can go through this, right? That will help you in fetching good marks. So once you know that, okay, this is the reason I am doing DALK, then let's go to the major techniques or important techniques of both anterior and posterior lamellar keratoplasty. So anterior lamellar keratoplasty and posterior lamellar keratoplasty. This is what the common clinical classification we divide. When we come to interlamellar keratoplasty, as I showed you in that table, it may be a Baumann transplant, it may be a Salk, Falk, or ALTK, or it may be a DALK, pre-descemetic, descemetic. So all these technique of anterior lamellar keratoplasty like ALTK, SALK, or Falk, these are reserved for cases where the opacity doesn't go beyond 250 micron. Okay, so in this case, you just remove the superficial layer and replace it with the donor cornea, right? So most of the time you need a microkeratome for ALK and ALTK and SALK. For FALK, femtosecond laser, you need a femtosecond assisted platform, right? So this is an example of microkeratome assisted interlamellar therapeutic keratoplasty. So this is an artificial interchamber. So donor, the point of showing this video is for donor preparation, you need a artificial chamber and Morias or maybe Gibbons microkeratome. And for host preparation also, you need a microkeratome. So once you have loaded the donor cornea, then you can customize the size of the blade you need to cut. Say, for example, this is, you can see here, and here you can here you can decide how much depth you want to cut. So if your opacity is, say, suppose 150 micron, take a donor tissue which is more than at least say 170 micron, and host definition or host microkeratome size should be 150. So just keep a gap of 20 micron and replace that with your a clearer donor tissue. So this is a microkeratome, Muria microkeratome. This is a older version, that's why it is running straight. The newer version, you have a circumferential microkeratome. So this is how you do the donor preparation. This is same for both SALK as well as ALTK. The only difference between these two is in ALTK, you can go little deeper because you put suture. So that was the donor preparation. Then this is a video showing host preparation. As you can see, the host is also prepared using a microkeratome head. With the suction ring, it keeps the eyeball tight, and then again you run the microkeratome and it cuts out it removes the anterior opacities, and you can get a clearer interface. After that, you can put the donor tissue and suture it in cases of ALTK. However, with the new technique like SALK, there you don't require to put a suture. You just can apply fibrin glue and put a BCL, and few people they apply some stay sutures also. So more or less both are same. The only difference is thickness. The examiner may ask you what is the difference between ALTK and SALK. So remember, SALK is basically restricted to those entities which are extending 130 to 150 micron. For ALTK, you can go beyond 200 micron also till 250 micron. In ALTK, you put suture. In SALK, you don't put suture. In ALTK, all suture issues are there. In SALK, even if suture is not there, but there are issues like graft dislodgement. If the patient rubs your eye or your fibrin glue is not good enough, then edge may be edge apposition. All these problems may be there in SALK. So these are few example of indications. Like the first one is, you can say there was some thinning with keratoconus. This was a case of spheroidal degeneration or climatic droplet keratopathy. This is a case of SND, Salzman nodular degeneration. This is a case of granular dystrophy. People used to do ALTK for granular dystrophy, especially when it is restricted to your superficial layers of cornea. Okay, so these are all the indication of ALTK, SALK, or FAL, femto-assisted lamellar keratoplasty. So this I have already told you. Since you are using a microkeratome, the next question may be why you are using a microkeratome. Why not go for a manual dissection? So if you use a microkeratome, the graft and host interface that is smooth, that will lead to less astigmatism and less aberrations, and the visual acuity may be as good as a PKP patient. But the limitation of this technique are they are costly. If you want to do this procedure, you need a microkeratome that would cost you almost 40 to 45 lakhs. And if you want to do FALK, not only the machine cost, for each procedure you will be spending at least 30 to 40,000 for that interface which is required for femto procedure. So these procedures are costly. This is an example of pre-op and post-op in Salzmann nodular degeneration. So once this SALK, ALTK, and FALK is there, and if the corneal opacity extends beyond that, what is next? Then the next option is you have to go for a deep anterior lamellar keratoplasty. It can be divided into two types, as I told you, pre-decimatic and decimatic. This is a review article we published in Eye and Contact Lens in 2014. If you people want to prepare for a long long essay type question, then you can go with this article. It has everything about that. So this is a very favorite questions among the examiner. They will ask you what are the different techniques of DALK. So remember there are 4 classical techniques and you have to remember their names also. So first is visco assisted technique or Malise technique, and that is the basis of this manual layer by layer dissection technique also, which we often do in difficult cases. The second technique is, so this is a manual DALK. I'll come to the video later on. Then second technique was big bubble DALK, and big bubble DALK was described by Anwar. Then third technique is, okay, it's not there in my slide. So I'll tell you, I'll just enumerate those techniques. So there are basically 4 techniques. The first was described by Archila et al. And that was an air assisted technique where you used to inject air and then create a separation plate within the stroma and then peel it off. So A for Archila, Archila's technique, remember, air assisted by Archila. Then came your hydrodelamination technique, that was by Sujita, where instead of air, they injected fluid into the stroma so that the stroma loosens and then you take it off. The stroma, you separate the dissection. Then came your Melis visco-assisted technique, where in addition to air, some viscoelastic was injected from periphery by creating a tunnel, and then dissection was completed. And then came your Anwar's air big bubble technique, which is the gold standard. Nowadays, almost all the DALK are big bubble or a modification of that because of the newly described Duas layer. Okay. So you just need to remember the names, okay? But you have to know a little bit about the manual LK because this is a very commonly done procedure, especially in cases of healed keratitis or healed hydrops in keratoconus with healed hydrops where you are not sure about the descemet membrane and you don't want to go deep, okay? Or when the cornea is extremely thin. So this is the technique. I'll show you the basic steps of manual LK. So this is a microscope integrated OCT. You can see on the right side. And this, what I'm doing is I'm scanning entire my cornea 360-degree to see how the thickness varies. So in some cases, the thickness, as you can see here, the cornea is quite thin in one particular quadrant. So big bubble technique carries a risk of perforance in such thin corneas. And classically, people avoid doing a big bubble DALK when the thinnest point is less than 250 micron. Because there was a study where they found if your thickness is less than 250 thinnest point, then the chances of perforation are high. So below that, usually people avoid going for a big bubble DALK. So in manual LK, the trick is you have to remove layer by layer. And what you can do is you can start with a small nick and then keep on using your lamellar dissector and remove it layer by layer. So few things you should remember, in cornea, this may be asked in your exam. Your examiner may ask you. The cornea anterior layer are interwoven and they are very tough. But the posterior layer are little bit more parallel and they can be easily dissected. So if somebody asks you how would you know that you are reaching deeper layer? So you can say that you can tell them you can answer in this way that the more deeper you go, the more easier is the lamellar dissection because the fibrils are arranged parallelly. And this surgery, I'll go back again because I'm doing a little modification here. So this is how you start. Start with a neck, then keep on enlarging it both circumferentially and centrally. Okay. And in this technique, this is a modification, little modification. What I do is in keratoconus, it's never that central 8 mm is thin. At times it may be eccentric like this. Okay. So when your cone is eccentric, thinned out till limbus. So what I do, I took a central 8 mm graft and then create a pocket. And I prepare a graft in such a way that there will be central 8 mm graft with some extra tissue here. So I call it as a customized DALK. When it is done 360-degree, people call it stuck-in lamellar keratoplasty as described by Professor Rasik Bajpai. So this is what I'm doing. I'm creating a pocket. But for PG level, no need to remember all this modification. Just remember manual dissection by layer. And indications are healed eye drops, extremely thin corneas, healed keratitis, where the chances of big bubble perforation is high. So there you do this lamellar. These are the lamellar dissector with which I am doing. Okay. So once you have achieved a particular plane, as you can see here you can see, and yes, here I'll little bit pause and tell you some theory and some viva questions regarding this. So there was a study where they found that by Reinhardt et al. It's in published in AO. So the examiner may ask you, see, this is the thickness of my residual bed. Is there anything related to if the residual bed thickness is related to your visual outcome? Then your answer should be yes. So the study by Reinhardt, what they found that if your residual stromal thickness is more than 80 micron, then the visual quality is poor. If you do a DLK and you are leaving more than 80 micron thickness, residual stromal bed. If you are living somewhere between 20 to 80 or 20 to 60, the visual acuity will be better. However, your glare and contrast may be poor because you are leaving some stroma. If your residual stromal thickness is less than 20 micron, then the visual acuity is as good as your penetrating keratoplasty. So this is a favorite question for cornea examiner. If your examiner is senior cornea surgeon, he may ask you. And also it may come in your SR shape or fellowship MCQs. So the study suggested if you achieve less than 20 micron residual thickness, then the vision may be as good as penetrating keratoplasty. So here I'm preparing the donor with a artificial chamber because I was doing a customized LK. But normally remember when you are doing a routine DALK, you don't need a artificial chamber. Okay. You just, yeah, this is the tip. So you just refine the post donor cornea and stain the Descemet with trypan blue because you don't want to transplant the Descemet of the donor because your host has already some stroma and Descemet layer. So put some drops of trypan blue and using a Merocell spear or some iris repository, anything you can rip off the Descemet layer and then you transplant. In this technique, what I'm doing is I'm doing a customized LK. So I'm taking a little flange to support my thin cornea in the periphery. Okay. Or otherwise, in a routine manual DALK is just a 8 mm graft. So you have removed the disease stroma and replaced it with a host stroma. No need to do all these tuck-in techniques. So this is what a manual DALK looks like. And then suturing, people do interrupted suture and few people prefer continuous suture also. But if examiner asks, is there a difference in the outcome? So there is a study where they found that when you they compared the three type of suturing, interrupted, continuous may be torque and anti-torque. They found that the ultimate visual outcome is same. The astigmatism that is induced by all these three types of suturing at the end of 6 months was almost same. So you can answer that all the technique have their advantage, disadvantages, but they don't have any impact on the final visual outcome. The advantages of interrupted suture is all this penetrating keratoplasty patient, the suture may become loose in postoperatively. Then you can take out one suture. If it is a continuous suture, you'll have to do suture adjustment, which is very difficult, and you need a lot of experience to do that. So this is how a standard DALK is done. Initially, you have to put 4 sutures, and remember this diamond shape. This diamond shape has to be uniform and equilateral from all sides. If that is there, then the post of astigmatism will be less. Again, one viva question is there. Some examiner may ask you, what is the single most important factor that decides your post of astigmatism? So remember these four sutures, they determine your post of astigmatism if they are equally placed at equidistance with equal strength. The chances of getting post-op astigmatism is very less. So these four stay switches are the most important for post-op astigmatism. Okay, this is microscope OCT. You can see I've just taken this. You can see this is the residual host stroma, and this is what the donor stroma looks like. And here this is fitting into your host bed, right? So this is what is a manual DLK looks like, right? Then came your big bubble DALK. In big bubble DALK, it exploits the potential gap between the Descemet layer and stroma. Embryologically, both your Descemet and stroma are from different sources. So there exists a potential space. In general medicine, you have read about ascites, right? What happens whenever there is some inflammation, some fluid seeps in and there is some ascites, there is some pericarditis, so there is some pleuritis. So whenever there is a junction of two embryologically different layer, you can exploit that gap. So this is what is being done in Anwar's big bubble technique. You inject air into stroma by a force, and the air will find the least possible resistant path, which is the junction of stroma and Descemet, and it will go into that space, and that will create a bubble. Once the Descemet is separated from your stroma, then it is easy for you to take out the superficial stroma. However, remember, it's not that simple technique. It's a very difficult technique. And then subsequently, Dr. Harminder Dua, he came up with this Dua's layer. Okay, then that made our life little bit easier, because instead of going till Descemet layer, we go till Dua's layer. Dua's layer, I hope you or pre-Descemet layer, I hope you all know that it's a layer, basically a thickened stroma, and it's almost 7 to 14 micron. It is just in front of your Descemet layer. Okay, and the advantage of this is it has more tensile strength than your Descemet layer. So if you are planning a pre-Descemetic DALK or pre-Duas DALK, then the chances of intraoperative Descemet rupture is very less. So it is a very safe technique. Also, the visual outcome is almost at par with your big bubble DALK. So this is the case of macular dystrophy. I have chosen this case because I will show you both type of bubble here. So remember, classically type 1 bubble is when you get a pre-Duas bubble. Type 2 is when you get a pre-Descemet bubble, and type 3 is a mix of that. So this is how you do it, DALK. The first step is, this is a vacuum trephine, remember. Okay, the most commonly used company is Hesburgh Baron trephine. So you see these 4 spokes, right? So the first step of achieving a big bubble is, what you have to do is, first you have to create a trench of 70% depth in the host stroma. Then you go into that depth and inject air. Then that will reach the Descemet and stroma junction. So to achieve that exact 70% depth, you need some trephine which are metered, or that will tell you this much depth you are in. So remember these 4 spokes, each quarter when you move, that will cut your 63 micron depth. So suppose your cornea is 500 micro, right? And you want to reach 70% depth, then you have to go till 420, right? So if 420 is there, one complete rotation, 63 multiplied by 4, that will cut almost 240 plus 12, 252, right? So what you will do, you'll go for a full circle and then another 3/4. So that will reach you almost 70% depth. So that is the advantage of using this Hesburgh Baron or vacuum trephine. So this is what I'm doing. I'm trying to reach a 70% depth. Okay, once I reach there, then I will debulk the superficial layer. Again, this is subjective. Few surgeons, they prefer to inject the air first and then debulk. Few surgeons, they prefer to debulk first and then inject air bubble. Okay. So once you have removed the superficial layer, you can inject air. This is a 30 gauge needle with a 2 ml syringe or 5 ml syringe I am using. So you inject with a force. Now you see what happened here. So the moment I am injecting, so the air went into 2 spaces basically. You can see one bubble is formed here, which is a central 8 bubble. And there are some bubble that went into a different layer also. So microscope OCT will help you know what actually I achieved in this case. So yeah, so this picture will tell you exactly and make you understand what is Duas there and what is. So you can see there are 2 membranes here, right? So this is Duas layer and this is your actual Descemet membrane. So here you can see Duas layer extend from in the set. It's there in your central 8 only, and it is quite firm. So when you get a bubble of Duas layer, you can see here, it will extend for only around 8 diameter, and it will end here. But when you reach the Descemet layer, this is the actual Descemet layer of the patient. So you can see the bubble extend from limbus to limbus, and it is, as you can see here, you can see the margin extending till here. But Dua's layer, the margin is here only, right? So when Dua hasn't described this phenomena or this layer, we used to consider this as a big bubble or some sort of complications. But nowadays, you can see in this image, the central 8 bubble that forms is primarily due to Dua's layer. But beyond that, it's the big bubble that is formed in your actual Descemet layer. So is this a challenge? No, it's not a challenge. In whenever nowadays, whenever we are at such situation, what we do a pre-Duas dalk only and leave this air bubble, or few people they go in and puncture this Descemet also, it's not going to cause any problem. So the basic steps of big bubble dalk, as I said you, first you have to mark the center of cornea, then do a vacuum trephine, go to 70% depth, then debulk the cornea, and then inject air with a force. Okay, so you can get three types of bubble. Type 1 where the Descemet, supradescemet, type 2 where you get a Duas layer bubble, and type 3 is a mix. In this case, I had type 3 bubble or the mixture of both. So once you achieve this bubble, what I did, I made a central nick here, as you can see here. Here you make a nick so that this air bubble comes out in a gush, and then you inject some viscoelastic here. You can see. Okay, so you see, I hope you notice that that air bubble coming out from here. But you see, I just punctured the superficial stroma that is above the Duas layer. And these three bubbles which are there in my pre-Descemet layer, they are still there, right? So once you do this, you inject some big viscoelastic as I am doing. You can see the viscoelastic is going into the layer that was created by separation by the air bubble. Okay. So then you cut the superficial stroma in 4 quadrants. Okay. So I'll just go a little faster. As you can see, I'll cut it in a 4 quadrant, and then I'll take out these pieces like this. Okay. Now you can see this is the thin transparent membrane, and this is the your Duas layer. Okay. And there is a bubble extending below that, and that is my actual Descemet membrane, but I am not going to remove it, right? As you can see, till the last moment of my surgery, and it is the end of the surgery. You can see this is the Duas layer, and one bubble is still there between the Duas and the Descemet membrane, and you can see here. Okay, but you can leave those bubbles; they are not going to cause any harm. Then suturing is similar to your manual dissect, like initial 4-stage suture, and then complete the rest of the suturing. One question may be asked to you in exam: what is the difference between suturing in a lamellar keratoplasty and a penetrating keratoplasty? Remember, in lamellar keratoplasty, we put little bit tight sutures, okay, especially in cases of keratoconus. But in full thickness graft, the goal is just to approach with little bit strength to the graft host junction. That is the difference. And in PKP, almost all the sutures are 90% there. In DALK, you can customize your suture depth, set 70, 80 or 70, 60, depending on the mismatch between your host bed and the thickness of the donor tissue. Okay, so this is an example of big bubble dark where I got a mixed bubble. Now the problem, as I said, okay, if three bubble appears, then it's very difficult to know whether your bubble is supradescemet or in the pre-Duas layer. So what people did, they did a lot of modification. You are not required to know the details of this for postgraduate level, but at least you should remember the name. So one of the technique was double bubble sign. The double bubble means once your bubble has formed, you inject a bubble in entry chamber. Since your Descemet is like this, it will push the second bubble to periphery. That is the concept behind double bubble technique. And then some small bubble technique. So these are all modification of Anwar's big bubble dark just for the ease of identification of the big bubble formation. Okay, this is a schematic depiction, right? Your big bubble is here. When you inject a bubble, another bubble into entry chamber, it will never go to center. It will stay in periphery. So that will tell you, yes, your bubble has formed. Then little bit about femtoacetate dalk. I told you the most important part for DALK is the initial 70% depth definition. So femtosecond can give you a tunnel exactly at 70% depth. And then you can go in and inject air bubbles. So that is the advantage of femtosecond dalk. But it didn't, this technique was not adopted by many. So it is very costly. And your vacant refiner as good as femtosecond laser to give you the accurate depth of thickness. Okay, accurate depth of definition. Now, completion of dalk, I'm not going to details of this. As I said, it's not required for a PG student. But these are the important complications. Descemet membrane perforation. Remember, there is a micro perforation, there is a macro perforation. Micro means when the size is less than 1 mm. For such cases, you can simply inject air bubble and continue with DAL. But in the perforation is large, you have to convert it into a full thickness graph. And one MCQ you may get, what is the rate of perforation in big bubble DAL? Remember, in the hand of Anwar, the technique was only 78% successful. So 22% is the failure rate of big bubble DAL. Pseudo anterior chamber, I'll show you one picture. It's basically fluid remains between your descemet and stroma. So that is pseudo anterior chamber. Uretz Zavalia. Uretz Zavalia is persistent dilatation of the pupil, especially seen in cases of keratoconus where there is the hypothesis that because of air and all this, there is some atrophy of the dilator muscles. Interface wrinkling, as I told you, because there is two junctions. One is host stroma and then the donor stroma. There may be haze. And in keratoconus patients, the posterior cornea is tipped like this, right? And you are exactly putting a 43 diopter host donor cornea. So that will push the ectatic descemet below. So that will produce wrinkling. That is another complication of DALK. Epithelial stromal rejection, since you are not transplanting the endothelium, whatever rejection is there, it's either the epithelial or the stromal. And last is interface keratitis. This is one of the worst complication, especially earlier cases. If you don't preserve the donor tissue properly, and there are organisms like Candida that can cause your interface keratitis. Once the infection is there in the interface, it's a closed chamber. So it's very difficult for antibiotic to reach there. And most of the cases, you have to do a therapeutic penetrating graft. So these are the major complications of DLK. One common complication that occurs in post-op period, I'll just show you for your better understanding. This double entry chamber, as you can see, this was a dark patient, and you can see here two membranes with fluid in between. So this is your original entry chamber. This is fluid between your Duas layer and your descemet membrane, and there is fluid between your stroma and Duas layer. So this is what is a double entry chamber. You know? There are three, rather here you can see a triple entry chamber. This is a very common complication. So normally, if the extent is less than 1 mm, you can simply observe that results on its own. However, here you can see it's a quite extensive double entry chamber. In those cases, you have to remove few suture, inject air, achieve an airtight chamber, and then you can simply remove few sutures and use a Merosil sponge which has some capillary action to dot the fluid. But here, as I told you, there is some fluid between your Duas layer and descemet membrane also. That was actually viscoelastic. So I had to puncture the descemet membrane to remove those. As you can see, some viscoelastic bubbles were coming. So these are the complications, very common. This is a complication that can be there in DLK patients. But no, most of the cases you can manage without any major complication, right? So then I'll move on to the posterior lamellar keratoplasty. It's difficult to cover all the topic in one session, but I'll just touch upon the two important techniques of posterior lamellar keratoplasty, which is DSEK and DMEK. The basic difference between DSEK and DMEK is, as you can see, S. S means stroma. So in DSEK, you are leaving little bit of stroma along with your endothelial descemet complex. In DMEK, you are not leaving any stroma. That's why there is no S. Okay. So that is the basic difference you should remember. This is again a review article by me and Professor Namta Sharma in IGO. It's free to download. You can go through this. You'll get all the information related to descemet endothelial keratoplasty as well as DMEK also. So in DSEK, remember the donor preparation is little different from DMEK. In DSEK, either you do a manual dissection or again, like ALTK, use a microkeratome. At RP Center, we do use microkeratome. We have that. If you don't have that, you can use a manual method also. And remember, when you're doing a manual dissect, it is called DSEK, descemet stripping endothelial keratoplasty. When you're using a microkeratome, it's called DSAEK, descemet stripping automated endothelial keratoplasty. This is how microkeratome works. This is a microkeratome of Gibbard. Basically, this is the enter chamber. You load the corneal tissue. You can see here, this is the corneal tissue that has been loaded there. Then you decide the size of this blade. Okay, how depth you are going, depending on the thickness of this donor tissue. Suppose your descemet donor tissue is 600 micron. So our goal is most of the time to get a thickness less than 100, which we label as ultra thin dissect. So if it is a 600, then I'll try to take a blade on a microkeratome head, which is going to cut superficial 500 micron. if you see this intraosity picture, okay, so I'll begin from the beginning again. See the microcuratum is going on. Now, once it is back, you can see this junction, right? So this is the junction. So this microcuratum blade, it has cut the donor tissue exactly here. You can see this line. So this is the superficial part. Now this is the posterior part. In dissect, we discard this superficial part and we take this stroma with with descemet and endothelium complex for transplantation. Okay? So this method is DSAEK. Suppose I would have done a manual dissection instead of microceratum using knife only. I would have gone here and with a knife I would have dissected this layer manually only. Then that would have been labeled as DSEK, descemet endothelial keratoplasty. Then DSEC, how it is done, I'll just tell you the basic steps. You need not to know the details about the procedure. Okay. Okay. So once your donor tissue is ready, next is your host preparation. Okay, you can see here. So basically, the DSEC consists of using a main tunnel incision, one artificial chamber, and few side port incision. Okay, what we do, you can see this is a reverse Sinskey hook. I will try to remove a central 8 mm of diseased endothelium from the host, and then I'll replace that with the graft that I have prepared. That is the basic principle of any DSEC or even DMEC procedure. So the instrument that you need is reverse Sinskey, as you can see. One question may be asked, what about the tunnels? Okay, so you can go for a clear corneal tunnel, or few people they do scleral tunnel here. Okay, you can go for a scleral tunnel also. Either way, you can make a tunnel. So this is what I am doing. It's a Descemet scoring. As you can see, with the reverse Sinskey hook, I am trying to remove the host Descemet, which came out quite nicely. I hope you noticed that. You can see this is the disease host Descemet endothelium complex I am removing. Right. The next step is, you can see this is a Bucin glide. This was the host tissue. This was the donor tissue that we prepared. Okay, we discarded the anterior part. We took the posterior graft. Now this is a Bucin glide. So this is the glide to inject your donor tissue. A question may be asked, what are the other methods? Remember, you can use a forceps, but nowadays we don't use that. Second, you can use a glide, which can be a Bucin glide or TANS endoglide or sheet glide. In India, especially at LBPI, when I was a faculty there, they used to prefer sheet glide because it is not only cost effective, but in India, especially when the interchamber is shallow, it prevents the iris from coming out. I'll show you while showing the next step what it does. So there can be Bucin glide, there can be sheet glide, or there can be tan endoglide, or there can be forceps, or there can be endosetter. Endosetter is a device just like your IOL inserting device. You load the tissue and inject it. Okay. So the technique can be divided into push and pull technique or and only push in technique. Push and pull is this. I'm injecting with your Bucin and pulling it with a forceps. Push technique is when you use a endosetter. Okay. So this is the tunnel that I had created. Now my Bucin glide is tucked into the tunnel, and using a crocodile forceps, I am just okay. So I'm just, you can see this is the tissue. So I am going in, I am catching hold the tissue, and I am gradually pulling the tissue into my anterior chamber. Once it is inside the anterior chamber, the next target is you have to inject some air and apply adhesive. Now you can, I hope you can see. See, this is the graft that I have inserted into anterior chamber. This is the host tissue. Now my goal is to inject air here so that it goes up and stick to the tissue. So once I inject the air, you can see this is the donor that has been firmly adhered to the host tissue. So this is what is basically a DSEC. And if you notice here, this hyperfluid layer is your Descemet endothelium complex, and this is your stroma. So in DSEC, you are transplanting some extra stroma. The advantage of DSEC is you can do it in difficult cases. I am showing this video so that I can show you a little bit about the scleral tunnel. See, this is the Bucin glide magnified view. Yes, this is the tunnel. So I was telling you, you can use a scleral tunnel also. This is a scleral tunnel assisted dissect. And I usually prefer this because it gives you a sutureless surgery. And this is Bucin glide, as I've already shown you in the earlier picture. And this is how you pull. So Bucin glide is tucked into the tunnel, and you pull it with your forceps into it. Okay. And this is again the end poster picture. So this was a very challenging case. It was an operated graft with xeroderma pigmentosa. In such challenging situation, your DSEC works well. Again, this was a case of endothelitis with shallow AC, you know. So again, another case of DSEC only, I think, yes. So the first, the edematous epithelium is removed. Then you can see this was a corneocellular tunnel I am creating. Okay. And then rest of the step, here you can see the descemet is quite fibrotic and thick. This was the tissue that I had prepared using a microkerato. And then I'll inject the tissue using this Bucin glide. Okay. And this is the tissue, donor tissue that I am injected. Then injecting air, then you can achieve adequate tamponade so that this tissue fits well. Okay. So then come your DMEC. DMEC, donor preparation defense. This is a technique that I have described, published in Saudi Journal. Okay, this is sharp technique or Sinskey hook assisted roll preparation. Nowadays, earlier we used to struggle a lot. Nowadays, it has become quite simple because a lot of institutes, they are providing pre-filled descemet membrane. So you can see here, while in DSEC, DSAK, you needed a microkeratome. Here, you simply use your surgical skill to peel it off. This is a Sinskey hook. I am trying to make it a 360-degree frill. Okay, now once the frill is achieved, you can extend it a little bit more, hold it with a McPherson or specialized forceps and peel it off. So the biggest advantage of doing a DMAC is you don't need a microkeratome. And the cost, each microkeratome blade for one procedure costs us around 6,000. So that component is not there in DMAC also. So if for it's quite a boon for our Indian surgeons because the microkeratome is not that commonly seen in private practice as well as government setup also. So in DMAC, what you do is you peel the descemet layer. Okay. Then you put some mark because it's a very thin layer. You have to be aware about the orientation of the graft. Here, you can use some marker or I simply use a Sinskey hook. No need to waste money in costly instrument. You can do it with your own Sinskey hook also. And then you peel the completely the donor tissue. And this is the DMAC roll. You can see the clover leaf pattern. Okay, this is how the donor and endothelium descemet looks like. It was a case of herpetic endothelitis. It was a phakic DMAC. You can see this was the edematous cornea. So donor preparation, sorry, host preparation is similar to DSEC, but here we stay at clear cornea level only. Because if you do a corneoscleral and your blood enters into antechamber, then unrolling of the graft becomes very difficult. Initial step is almost like DSEC only. You take out the diseased endothelium descemet complex. Then you do a PI. In DSEC, you can avoid PI, but in DMEC, it's a must. And this was the graft. And there are several devices. Somebody may ask you some devices to insert. You can simply use some IOL injector, but if examiner asks you, you have to know few names like Jones tube, Goiter tube. Okay, so Goiter injector, Jones tube. You have to know few names to answer them. Like here, I'm using a Alcon Monarch cartridge only. You can see D cartridge. Yes, this is this is simply IOL injector only. You take it in and then inject. In DSEC, you have some stroma. So getting a donor host adhesion is quite easy. But here, the main challenge is unrolling this thin tissue. Okay. So once you unroll this donor tissue, donor roll, then your life becomes easy and you have to confirm the orientation with the mark, F mark that you off F or some people use P, which some people use S, any mark you put and then you have to examine. You have to check for orientation. So the difference is stroma. Here there is no stroma. And that reflects in your poster finding. It is the same surgical technique with a little bit longer video. You can see this was the day one picture of a DMEC patient. The cornea looks absolutely clear because there is no stroma and the patient is also very happy. So these are the advantages and disadvantages of DSEC and DMEC. If the examiner asks you, why would I do DMEC, not DSEC? The most important answer is DMEC provides you the best quality of vision, a higher rate of higher chances of getting 6/6 vision and least aberrations. Also the rejection rate because you are not transplanting stroma. So the rejection rate is also less in DMEC. However, the problem with DMEC is it needs some practice. It's not that easy to master this technique. Initially, when you try to do DMEC, you will waste a lot of tissue because peeling the descemet, If you don't peel it properly, the Descemet may rip off and the tissue may be lost. Okay. And post-op complication. This is a thin membrane. Okay. So the chances of graft dislocation or graft dislodgement is little high in DMEC compared to DSEC. However, vision quality wise, DMEC is best. In difficult situation, which I showed you, like failed graft, operated CHED patient, operated AGV, in those cases, it's better to go for a DSEC. Then lastly, this is the PDEC technique where Dr. Amar Agarwal, sir, he found that this DMEC rolling, unrolling is a big challenge. So what he did, he removed the pre-Duas layer, as suggested by Dua. So in addition to Descemet endothelium, he included Duas layer also. So that gave some little bit tensile strength and some rigidity to the donor tissue and ease of manipulation. Few people modified this further. Few people did a combination of DSEC and DMEC. Okay, so few people did DMAEK. They use a microkeratome prepared DMEC tissue. You should know these names because somebody may ask you which are the modification. What few people have tried? Hemi-DMEC. Hemi-DMEC means you take a DMEC tissue divided into half and use it at two endothelial grafts. But you are not required to know the details of this technique. Just need to know the names. I think with this, I conclude here. It's a difficult topic to cover in 1 hour, but I hope I told you the major things, major advantages, major points that can maybe ask you in exam. And I hope you learn something from the class. And with this, I'll conclude here. Thank you.
Thank you, Dr. Praful, for wonderfully elaborating and taking us through all the lamellar surgeries in cornea. Now, I think the topic is open for discussion. Can I invite all the discussion, Dr. Arundhati ma'am, Dr. Sandeep, and Ankit to add compliment to the understanding of our postgraduates? Why don't we begin it with the senior most person, Dr. Arundhati ma'am?
Okay, Praful, there was a very elaborate and very well detailed description. Only thing is, like what I've seen here is most of the government hospitals would not have an access to an automated system. Neither would they have a microscope with a OCT in it to know. So, like, just a few tips more on how to go about manual dissection. And because, okay, anyway, they won't be doing it as a thing as PG students much and all that. But that's what I've seen, that when we have to go and take classes to the PGs and the regional institutes and all, they don't see the automated system, and the microscopes are though higher, none of them have OCTs inbuilt it. So that is one something we need to tell them how to start the basics, like in their wet lab, how they go about dissection and all that. So otherwise, a very good, a presentation, I would say. Only that like it covers the whole spectrum, but if we are going to stick to postgraduates, mostly in the government medical college, as Prashant has said, I think they have very limited access to the automated system. And the
Very
complications.
true, ma'am. And this is what I said. If you are planning a career in cornea in future, you must learn DMEC.
Exactly.
DMEC gives you that liberty. You don't need a microkeratome, and quality of vision is also best.
Yeah. So that's the final takeaway message. And I think for beginners, I think even if you're doing a DSEC, it's always like better to mark, because they get confused which is the endothelium side and which is the stromal side, when they are doing the first few cases, So what we do routinely for DMAC, putting a signage of P, F, L, whatever, I think even in DSEC in the initial cases helps them to better orient, which side they are doing it. So I think otherwise you've covered almost
Yeah,
everything.
for beginners, ma'am perfectly said, you should not only mark it, and also there are few tricks for beginners,
Yeah.
but I think not required for postgraduate, like
Yeah.
scrap making venting incision. For
Yeah.
your exam purpose, you just remember this, what is DSAEK, what is DMEC, and how the donor is prepared. Overall, mota, no need to go for the details.
And I mean, you described beautifully. It's often what I may wanted to convey is whenever you describe, the institutes which do not have these, they say, oh, ye to hamara paas nahi hai, sun ke kya karenge? No, just to pass the exams and all. But then if we tell them more of the doable parts in there also, then they get more interested. But I think it's a perfect thing. You've described the whole spectrum from A to Z. Very good presentation.
Dr. Sandeep, your comments?
Sir, it seems the target audience is postgraduates. So probably Praful has covered everything. It's a very good presentation as far as assay questions are concerned. But I think there are some short notes or something. Short questions must also be a part of the curriculum. So probably then you have to target specific things about lamellar keratoplasty. Complication is one. Second thing, Praful, I think wanted to, but must have in a haste, didn't emphasize the quality of tissue can be okayish for a deep antilamellar keratoplasty, but has to be a one with a very good endothelial counts when you target the endothelial keratoplasty. So you cannot have a umbrella that okayish tissue can be used for endothelial keratoplasties also. And probably for short questions, few things like type of bubbles, type 1, type 2, type 3, what Praful has said, complications, indications, they all are covered, but the PG should keep in mind that these questions could also be asked where you have to write certain part of the presentation he has presented. Excellent presentation, Praful.
Point
Thank
sir
you.
is making. See, this class is to guide you and show you the major points, but it is not going to help you when it comes to nitty-gritty of lamellar keratoplasty. For that, you have to go back and study. Either read some standard textbook, and I quoted few review articles for you. If you have to, because nowadays, DNB pair I have seen the questions are quite advanced. Even you can get a question on Bowman layer transplant. For those part, you have to go back and study.
Dr. Ankit?
It was very informative for as far as postgraduates are concerned. And the same point which Sandeep sir said regarding donor tissue also, it's very important to check for the quality of donor tissue when as far as lamellar keratoplasties are concerned, especially endothelial keratoplasty. So ideal age, these types of question can be asked in the exam. What is the ideal age of donor tissue that should be used for DMAC, which is 55 to 75, to avoid complications during unscrolling of the roll. So these kind of things also should postgraduates also should consider while reading. So these are also important, as sir said. Other than that, I think most of the points have been wonderfully covered by sir.
Thank you. I think Dr. Praful, you have done a wonderful job and in fact left not much point for the other discussants to
Yeah.
really delve upon and really highlight upon. So I think we had a wonderful discussion. Exactly, we are in time. It's 8:59. So I think if no more questions, we can just sign it off. Any questions from any discussants, ma'am? Arundhati ma'am, you nothing.
Thank you for the opportunity.
Thank you. Thank you. So,
Thank
Doctor, postgraduates hope this particular talk on lamellar keratoplasty must have been quite enriching for you and must have cleared your basic concepts. And as Dr. Praful has said, that in event, whenever you go back, you have to go back to a bit into the books. Read now, it will be more, you will understand the topic in a better way. And this is just a guideline on which Dr. Praful has elaborated and made your life more easy and simplified. So without much ado, now it's time for us to say goodbye. Thank you, Dr. Praful, for taking all the efforts. I know you are having a big job, DOS, to start from Friday, Saturday, Sunday. In spite of that, you could spare time for our postgraduates. We are sincerely thankful. AISARC is indeed.
Thank you, sir.
Of course, to Dr. Arundhati, Dr. Sandeep, and Dr. Ankit for sparing their valuable evening with us.
you, sir, for the
Thank you,
opportunity.
everyone. Thank you once more. Bye-bye.
Thank you. Good night.